How's everybody doing? We are traveling down the electrical pathway of the heart. We've talked about the sinus family. Dysrhythmia is in the atriums, and now we're stopping at the junction, the AV junction. All right, everybody, if you're old enough to remember Schoolhouse Rock, here's a different version. AV junction, what's your function? Slowing down signals and backing up functions. All right, two main purposes of the AV junction are slow the impulse between the atrium and the ventricles, and it's a backup pacemaker to the SA node. Remember, if the SA node doesn't send that signal, then the AV junction will fire at an intrinsic rate of 40 to 60 beats a minute. Ask yourself, why do we need to slow that impulse conduction? Yes, you are correct. We slow that impulse conduction so the heart has time to fill up and we get that maximum stretch. And that stretch helps it squeeze a little more forcefully. We're going to start off by talking about AV blocks, and then we'll do junctional rhythms afterwards. The location of blocks are important. Those blocks either occur at the AV node themselves, at the bundle of His, or below the bundle of His. Low grade or low degree of blocks are first degree and second degree type 1. And those blocks are normally in that junction themselves. Then you've got the high degree blocks. High degree of death. High degree of death. Those high degree blocks are second degree type 2 and third degree. Those occur bundle of His or lower, and that's why medications normally don't work. We'll get into that shortly. All right, we mentioned these four in the last slide with the low degree and high degrees. Classifications are first degree, type 1 second degree, or second degree type 1, you can say them either way, or Mobitz 1. All kinds of names for second degree blocks. And then there's a type 2 second degree, or second degree type 2, or a Mobitz 2. All kinds of otherwise known as blocks. And then third degree block. And third degree is a complete heart block. No signals, the atrium's doing their own thing, and the ventricles are doing their own thing. So there are your classifications. First degree, second degree type 1, second degree type 2, and third degree. Get your charts out here. Remember, your 5-step rhythm recognition process goes on the left side of your chart, and your names of your rhythms go across the top of this chart to keep things in order. The rate of a first degree block depends on the underlying rhythm. It could be slow, it could be normal. So the rhythm is usually regular, the R to R interval. The SA or the pacemaker is in the SA node or in the atrium. The P waves are normal. Remember what we're looking for when we're analyzing P waves. We're looking to see if they're present, they're upright. The P waves are regular in association to each other. They are one for each QRS and they all look alike. That's what we're looking for. However, we've got to analyze this PR interval. And look, the PR interval is greater than 0.20. Remember, normal is 0.12 to 0.20, but with a first degree block, it is greater than 0.20. So, and there is still one for each QRS. The PR interval is just longer. PR interval is longer, as I mark the picture here. Longer. QRS is still less than 3 little boxes, or 0.12. First degree block. So it may occur in healthy hearts, but most time is indicative of ischemia. Remember, ischemia is hypoxic heart tissue. So it's just a precursor, precedes more lethal blocks. Treatment, as long as there's no serious signs and symptoms, there's not really any treatments for this block. First degree block is not really a block. No signals are really getting blocked. It's just a longer than normal delay at the AV node. Just a little longer than normal delay at the AV node. First degree block. All right, type 1, second degree, a Wenckebach. Second degree, type 1 or type 1 second degree is otherwise known as a Wenckebach. So the atrial rate is normal. The ventricle rate, depending on how many times it skips a beat, could be normal to slow. P waves are normal, but not every P is followed by a QRS complex. Not every P is followed by a QRS complex. Important there. And then we analyze our PR interval. Our PR interval increases until a QRS complex is dropped. We take a look here. It's this, oh, let's switch. Let's do this color. It's about that long, gets a little longer, gets a little longer until it drops a beat. And then it starts over. Hey, there's a P, short, a little longer, until it drops a beat. Second degree, type 1, like we said, Mobitz 1 or Wenckebach. It's a delay increase until an impulse is blocked. So if frequent QRS complexes are blocked, it could compromise cardiac output, but normally it doesn't. So generally treatments aren't required. However, if they have serious signs and symptoms and their rate is slow, we need to use that bradycardic algorithm. Second degree type 1, Wenckebach. Remember, Wenckebach walks away. Your P wave slowly walks away or elongates until a beat is dropped. All right, here are two examples of a Wenckebach second degree type 1 rhythm. Go ahead and copy this URL, paste it into another web browser, and enjoy the Wenckebach song. But look here, we've got one PR interval, gets a little longer, and then we drop the beat. Just like the one down here. There's the rhythm, gets a little longer, and then we drop a beat. Wenckebach, diagnosis Wenckebach. Go ahead and enjoy the video and come back to the presentation. Type 2 second degree is a high degree block. Type 2 second degree or second degree type 2 is a high degree block. High degree of death. So the rhythm can be regular or irregular. The P waves. Some P's may not be followed by QRS's. And in reality, we have more P's than QRS's here. Your PR interval is constant for conducted beats. Key here, folks. PR interval is constant for conducted beats. PR interval is constant for conducted beats. However, we have more P's than QRS complexes. A good way to distinguish second degree type 2. PR interval is constant. We have more P's than QRS's. And that QRS complex is normal. Less than 3 little boxes or 0.12. Type 2 second degree is also called Mobitz 2 or infranodal. Infranodal. And guess what, kids? That is a good quiz question. Second degree type 2, Mobitz 2 or infranodal. Intermittent blocks of impulse. usually associated with a myocardial infarction or septal necrosis, high degree of death. Locations, the bifascicular or left bundle branch, and tends to worsen with atropine. Ooh, tends to worsen with atropine. About 25% of these second-degree type 2s are in the bundle of His. So they're below the AV node. Second-degree type 2 blocks are below the AV node. Important when you're thinking about treatment considerations. Clinical significance, type 2 second degree, may compromise cardiac output, and like we said, is indicative of that myocardial infarction. So some heart tissue is already ischemic or starting to die. Treatment, avoid drugs that slow down that AV conduction. So second degree type 2, transcutaneous pacing. Pace this heart to a faster rate so it can squeeze out the blood it should. You can consider atropine. However, atropine works at that AV node, and we'll talk about it more later. So go straight to pacing. All right, a 2-to-1 AV block is just another type of second degree type 2, and these have exactly 2 P's for every QRS complex. Exactly 2 P's for every QRS complex, similar to second degree type 2. It's a second degree AV block where there are 2 P's for each QRS. Same type of thing, MI, septal necrosis, bad things happen. Prepare for pacing because it's below the level of the AV node. Prepare for pacing because it's below the level of the AV node. All right, third degree block, otherwise known as the complete heart block. So the atrial rate is normal. The ventricular rate, they say, is 40 to 60 beats because that signal is coming from the junction. The SA node and the AV node are the 2 sites, or the ventricles, depending. So P waves are normal, and there's no correlation to the QRS complex. So let's take a look at this. The P to P intervals are the same. Hey, there's one, it's buried. The P to P intervals are the same, and the R to Rs are the same, but they don't correlate. P to Ps are the same, R to Rs are the same. That means that PR interval is variable. The PR interval is variable. Big key indicator. PR interval is greater, the QRS complex is 0.12, and it may be greater depending on if the signal is coming from the AV junction or the ventricles. All right, a third degree heart block is a complete heart block, and there is no signals between the SA node or the atriums and the ventricles. That's why the P waves do their own things and the QRS complex does their own things. So the locations within the lower portion of the AV node, about 2/3 of those escape rhythms have a narrow complex because it's coming from the AV junction. So if the block is at the level of the bundle of His, it is still a narrow complex QRS. However, if the block is lower, trifascicular block, or a subjunctional, sub meaning below the junction, then the QRS complex is wide with this third degree heart block. Severely compromised cardiac output. Like I said, the atriums are doing their own thing, so that atrial kick is pushing blood when the ventricles could possibly be squeezing also, so they don't get filled up like normal. So treatments, if they have a serious sign and symptom, altered mental status, acute heart failure, JVD, chest pain, hypotension, signs and symptoms of shock, we need to pace them. Third degree heart blocks, second degree type 2 and third degree heart blocks, transcutaneous pacing, because atropine works at the level of the AV node. Atropine works at the level of the AV node, and these blocks are below that level. Low in the AV node, bundle his or lower. High degree of death. All right, locations of heart blocks. Remember that your RCA, right coronary artery, sends most of the blood for the electrical system. Some comes from the left, but most come from the right. And your 10th cranial nerve, that vagus nerve, is hooked to that AV node or AV junction. That's why atropine is a parasympathetolytic. The vagus nerve is hooked to that parasympathetic nervous system, and atropine blocks parasympathetolytic. Atropine blocks that parasympathetic nervous system signal, and if we block the body's brake pedal, the parasympathetic nervous system is the body's brake pedal. If we block that brake pedal, then our heart speeds up. And those signals are in the AV node, where the first degree heart block is at. And remember that first degree is just a delay in conduction, not a true block. And then the Wenckebach is also at the level of the AV node. So, and the Wenckebach walks away. Progressive elongation until a signal is blocked. So then you get the high degree blocks. And at the level of the bundle of his, the Mobitz 2, second degree type 2, bundle of his is below that AV node. So we should go to pacing, because atropine's not going to work on it. So, and then third degree can be low in that AV node, at the bundle of his, or in the trifascicular areas. That's way below subjunctional areas. And atropine won't work on third degree blocks. So know your locations and know when to use atropine and when to go straight to pacing. Most people have a difficult time with AV blocks, but if you just use this algorithm approach, it'll make things easier. You look at the rhythm, you do your 5-step rhythm recognition process, and you're like, man, I know it's a block, but I don't know what kind it is. Evaluate your PR interval. If your PR interval is constant, then we're going to look for your P's to QRS's. If the PR interval is constant and you have 1 P for each QRS, you have a first degree block. Everybody with me? All right. If you have more than 1 P per QRS, you have a second degree type 2. Remember, second degree type 2s have constant PR intervals for conducted beats, but they have more than 1 P for each QRS. So if the PR interval is constant and you have 1 for each QRS, it's a first degree. If you have more than 1 for P for each QRS, it's a second degree type 2. Then if you evaluate your PR interval and that PR interval is variable, you look at your R to R interval. If your R to R interval varies, you have a second degree type 1, because the Wenckebach walks away. Progressive elongation of the PR interval until it drops a beat. Got it? So variable PR interval, variable R to R interval, second degree type 1. If you have a variable PR interval, but you have a constant R to R interval, you have a third degree. Remember that in the third degree, R to R's will be constants and P to P's will be constant, but they don't correlate, so it's a third degree. I hope that helps out. Go through these steps. Makes it simple. Most of the time with these heart blocks, it's going to be a slow rate, so we're going to be using that bradycardic algorithm. Remember our memory jogger for the bradycardic algorithm. Always pace, dangerous events. Always pace dangerous events, and that means atropine, 0.5 milligrams every 3 to 5 minutes, up to 3 milligrams. If that doesn't work, pacing. Remember the steps of the pacing process: pacer, rate, current, capture. And that capture is electrical and mechanical. If that doesn't work, dopamine, 2 to 20 micrograms per kilogram per minute, and then an epidrip, 2 to 10 micrograms per minute. So remember that bradycardic algorithm. All right, now we're moving into AV junction dysrhythmias, not blocks, but dysrhythmias. And the location of that pacemaker will dictate the morphology of the P waves. If it's coming from the SA down, it's going to have an upright P. However, if it's coming from the AV junction and going backwards towards the SA node, that P wave will be inverted. Wow. Remember, the intrinsic rate of the AV junction is 40 to 60 beats a minute. 40 to 60 beats a minute. And just like this picture shows, it starts here. Let's try a different color. Picture starts here and goes backwards. And that's backwards shape is why the P is inverted. Got it? Sweet. All right. Characteristics of all junctional rhythms. Inverted P's. This smiley face is just to represent the inverted P from our isoelectric line. The PR interval, since the signal is coming from the AV junction, that PR interval is going to be less than 0.12. And the QRS complex is going to be less than 0.12. So things are jammed up pretty close together. So you may see these P waves before the QRS complex, after the QRS complex, or they may be absent, which means they occur in the middle of the QRS complex. So remember, the P wave may be before, after, or in the middle of the QRS complex. And you bam the inverted P waves at the junctions. The junctional rhythms include PJCs, premature junctional contractions, junctional escape, complexes or rhythms, junctional bradycardia, and accelerated junctional rhythms, meaning accelerated junctional rhythm or junctional tach. We'll talk about them all. Here we go. All right, here are two examples of some junctional rhythms. You see the inverted P waves, the shortened PR interval, and still a narrow complex QRS. So it can come before, P's can come before the QRS complex, or it can come after. Or they can be absent. So remember, we're bamming the junction. We are bamming the junction. B, before, A, after, or they're absent, which means they're in the middle of that QRS complex. Bam the junction. Let's talk about PJCs, premature junctional contractions, depending on underlying rhythm for the rate and the rhythm. So pacemaker site is an ectopic focus in the AV junction saying, I want to start the wave. P waves are inverted. They may occur before, after, or in the middle. So you get your calipers out to see if your rhythm is regular, and you go down the line, and then you say, hey, that ain't right. We're a little short. You analyze your P wave, and it appears a little inverted compared to the other ones. Look at this one as compared to this one. Looks a little inverted, and that's a PJC. P or interval is normal or short, dependent, and the QRS complex is less than 0.12 or 3 little boxes. The PJC is a single electrical impulse that pops up in that AV node. Tobacco, alcohol, cocaine, caffeine, all those kind of things can make these PJCs or your junction unhappy. So clinical significance, if it doesn't happen very often, then there's no issues. But if it happens frequently, then there could be some problems. With your PJCs, there's a compensatory pause. Now, it's up to you to tell me what a compensatory pause is. Get ready for that quiz question when we get to class. Treatment, usually none if there's not many. The junctional escape beat or junctional escape rhythm. Remember, those escape beats or rhythms escape from death or escape from cardiac standstill. If the junction doesn't get a signal from the SA node, it takes over and sends signals at a rate of 40 to 60 because that's the inherent rate of the AV junction or AV node. So the rhythm may be irregular if it's just a single escape beat, or it could be regular if the signal is coming from that junction at regular intervals. The P wave is inverted. P wave's inverted, just like this crazy little picture right here. Inverted. And remember, it could be before, after, or in the middle, so you can't see it. So QRS complex is normally less than 0.12 or 3 little boxes. In this junctional escape rhythm, the AV junction is the pacemaker. Could be increased vagal tone from that parasympathetic nervous system, which is the body's brake pedal, that slows that discharge and the AV takes over. If it gets really slow in that 40 beats a minute range, it could decrease cardiac output. So if they are asymptomatic, we are monitoring and observing. If they are symptomatic, they have a serious sign symptom, altered mental status, acute heart failure, JVD, chest pain, hypotension, signs and symptoms of shock, bradycardic algorithm for this slow rate. Next is the junctional bradycardia. Remember, our intrinsic rate of our AV junction is 40 to 60. So if we are a bradycardic rate of normal, we are less than 40 beats a minute. Less than 40, because that's the low level of our junctional intrinsic rate. So P waves inverted before, after, or absent, which means they're in the middle. So junctional rhythms, we bam the P waves before, after, or in the middle, and they are inverted. So QRS complex is usually normal, but may be greater than 0.12 if that signal is starting to come from the ventricles, depending on the signal. If it's coming from the junction, it'll be narrow. If it's coming from the ventricles, it'll be wide. When your heart beats less than 40 times a minute, you are going to have a decreased cardiac output. So prepare for transcutaneous pacing and the other steps in that bradycardic algorithm. Remember the memory jogger, always pace dangerous events, atropine pacing, dopamine epi, for this very slow junctional bradycardia. All right, accelerated junctional. Accelerated junctional. We are going faster than a junctional rate. Remember, our junctional rate is 40 to 60, but our accelerated junctional rhythm is 60 to 100. The pacemaker site is the AV junction, so we're gonna have inverted P waves. They could come before, after, or in the middle of the QRS complex, and you won't see them. And that QRS complex is less than 3 little boxes or 0.12. But this doggone rhythm looks crazy. When you see something looks crazy, go through your 5-step rhythm recognition process to identify those rhythms. Accelerated junctional. How's it occur? Ischemia. Hypoxic AV junction. It's usually well tolerated because, well, your heart rate's going at the normal cadence. So look at this one. We've got a 1, 2, 3, 4, 5, 6, 7, 8. 80 beats a minute on this rhythm strip. We've got inverted P waves. So this is in between 60 and 100 beats a minute. So it's accelerated inverted P waves. Accelerated junctional. It is that easy. Next is junctional tack. Things are going fast. Over 100 beats a minute. So rhythm is regular. We're tacking right along, regular beat. Inverted P's. The P's are inverted. They can come before, after, or in the middle of the QRS complex when you won't see them. And that QRS complex is normal, less than 0.12 or 3 little boxes. Junctional attack is caused from increased automaticity. Things are going fast here in the AV junction. Could be caused from digitalis toxicity, an MI, isoproterenol infusions, sick sinus syndrome. We swing from slow to fast and back again. Signs and symptoms. When your heart's racing, it may be feeling like it's beating out of your chest and it's palpitations. It's gonna jump out of my chest and run down the road. Can you catch my heart? They can be fatigued, poor exercise tolerance. They may try to do something and just be too tired to do it. They may pass out or have a syncopal episode. If it gets fast, over 150 beats a minute, and it's narrow, we need to treat it like SVT and slow it down. Try and figure out if they are stable or unstable. If they're fast and unstable, or synchronized cardioversion. If they are fast and stable, vagal maneuvers. Adenosine, 6 milligrams rapid IV push, followed by 20 cc flush in 1 or 2 minutes. 12 milligrams rapid IV push, followed by 20 cc flush. Calcium channel blockers or beta blockers. Remember that fast and stable or fast and unstable treatments. Fast, stable, and narrow. Fast, unstable, synchronized cardioversion. All right, we're back to everybody's favorite slide. In summary, remember with our AV blocks, if you can tell it's a block but you don't know which one, evaluate that PR interval. If the PR interval is constant and there's 1 P for each QRS, it's a first degree. If that PR interval is constant and there's more than 1 P for each QRS, it's a second degree type 2. If the PR interval is variable, then look at the R to R interval. If the R to R interval varies, it's a second degree type 1 because a Wenckebach walks away, that P wave walks away from that QRS complex and then it drops a beat. If the PR interval is variable and the R to R interval is constant, then it's a third degree. The P's will be doing their own things and the R to R's will be doing their own things, but they don't correlate. So it's a third degree complete heart block. Remember with junctional rhythms. The intrinsic rate is 40 to 60. So a junctional rhythm is in that rate with an inverted P wave, and we bam it. Those P waves either come before, after, or in the middle of the QRS complex, and you won't see them. So a junctional bradycardia is a rate less than 40. An accelerated junction is between 40 and 60, and a junctional tach is an inverted P with a rate over 100. I hope you enjoyed this presentation. Have a great day.